I believe you're all well. I welcome you back to my YouTube channel. My name is JEMIENAFTALY on the pediatric world. So this channel is all about the kids' welfare, the medical problems, and we try to find solutions. We want to create the awareness. We want people to have the knowledge on the common illnesses that children get while growing up. And here we talk in a language that everybody is able to understand. We want to be as layman as possible here, and so that this information people may get to know everywhere, from every corner. We want to add you into management of these babies. So welcome to my YouTube channel. And today's episode, we are going to continue on, remember where we left last time. We're continuing with treatment of dehydration in different classes. And the last episode we treated the hypovolemic shock, the severely impaired circulation we treated. And now today we are going to go straight to treatment of severe dehydration, the second classification of dehydration. So we said this requires use of IV fluids, both the hypovolemic shock and now the severe dehydration. We need to use IV fluids, intravenous. Those we put the fluid through the vein, that is the intravenous fluid. And we said the best fluid to use is Ringer's lactate, and we gave reasons. Please visit the other episode. We're going to use Ringer's lactate also here in severe dehydration. We also said that if Ringer's lactate is not available, we can use normal saline. But the best one, the first line fluid of use is Ringer's lactate. So what we do, we want to give this fluid therapy immediately and quickly because we are at severe dehydration. So we are fearing that the babies, if we waste time, the babies will go into shock. So they will go into shock. It's what we want to prevent. So we give the fluids very, very fast. The treatment should start very, very quickly. So we start by accessing an IV line. We do the intravenous line. Here we try to access it. And after we get it, the treatment is in two phases, and we mentioned it somewhere. So the first phase, we are going to use, first of all, we are aiming at giving 100 mils. We are aiming at giving 100 mils over 24 hours. So the first phase we are giving 30 mils per kg. And if the child is above 1 year, we give this 30 mils over 30 minutes. If the child is less than 1 year, we give the 30 mils per kg over 1 hour. So the age is very important, and the age and the kg is what we are using in calculating these fluids. Please don't just give, please remember that. So that's the first phase of giving 30. The second phase is by doing 70 mils per kg, and we are giving over 2.5 hours if the babies are above 1 year, and we are giving over 5 hours the 70 mils if the babies are below 1 year. So, and this is the 30 and the 70, it's now giving us 100 because we said we are aiming at giving 100 ml of Ringer's lactate. So, excuse me, hope that one is very, very clear. We said in shock, just to take you back, in shock, after we have given the first fluid, after the child has improved, we don't go to start now the first phase of 30. No, that one we skip that part and we go direct to 70, the second phase, the 70 mils per kg of Ringer's lactate. That is very, very clear, especially to professional caregivers, just to remind you. And after giving every amount, we reassess. We try to see if we have come out of this severe dehydration. Have we improved? And then if we have improved, now we have gone to some dehydration. We are happy. We are happy after improving that we have gone now to some dehydration. If still there's no improvement after giving the 30 mils and the 70 mils, we can repeat the same, another 30 and 70, and again reassess. And we know we have improved by even improving with signs. So in severe dehydration, we said the child is not able to drink. So if we find the baby is able to sip, we are happy, and we say now we have proceeded from severe dehydration to some dehydration. So these are some of the ways that we try to see to if we have improved. So we said, and if we have improved, if the child is able, as soon as the child is able to drink, we can give ORS, the oral rehydration salt. So we can give that if the child has improved. So we assume our child has improved after giving the Ringer's lactate 30 and 70 of the severe dehydration, and hence we have moved now to some dehydration. How do we treat some dehydration? Remember, some dehydration, we said we are using our common thing, which is ORS, the oral rehydration salt. So we said the advantages of ORS in the previous episode. And here in some dehydration, we are able to say the child is having some dehydration now when the child is able to feed. The child is able to drink by their own. They have some irritability. Remember the signs and symptoms of some dehydration, just to remind you. And so we give ORS at 75 mils per kg over 4 hours. So here we do not do the IV fluids. We do not do the Ringer's lactate. The Ringer's lactate was for hypovolemic shock and for severe dehydration. So we give 70 mils of ORS per kg over 4 hours. And then from here we again reassess. We reassess to see if we have improved, and again if you haven't, we repeat the same 70 mils per kg of ORS. If we have improved, this tells us what? That we have improved from having some dehydration to having no dehydration. And we are happy again because we are improving. So caregivers should know how to use the ORS. You know, we just go to the over the counter and buy the ORS. Maybe they are not told how to use it. They should know that ORS is given slowly, because imagine when you give so fast and the aim here is to rehydrate, then the child starts vomiting when you give so fast, and we want to retain this fluid, so we are not doing anything. So we advise the moms that ORS is given so slowly to avoid vomiting. And frequent sips are ideal. You just don't give the whole of it so fast. So we keep giving slowly, and the aim is to retain some. Also, when we are using ORS, mothers should know and should be encouraged to continue breastfeeding and giving other feeds. We do not stop at just giving the ORS and continuing with that. We also want to feed the baby. If the child is breastfeeding, we keep breastfeeding these babies, because we remember we said in breastfeeding we still have some fluids, and we are again rehydrating through breastfeeding. You know that? You knew that. So just to know. Again, an NB, note that vomiting is not a contraindication to using ORS. When I say contraindication, I mean if the child vomits, that does not prevent you from giving ORS, because the child has vomited, now you stop giving. No, it is not a contraindication. So you should wait for some few minutes, like 10 minutes, and then you resume back by giving the ORS again so slowly. Remember, we don't want to be so quick. So that's what we mean. So those are just things to note about the ORS. Most people use it, maybe they don't know this. So now you know. So our baby has improved from some dehydration, and now to where? To no dehydration. We are happy now. We are happy. We've moved to no dehydration. So then, treatment of no dehydration. The aim of treatment here, we want to prevent. We remember we said the no dehydration. Yes, the babies have diarrhea. They have diarrhea episodes, but we do not have dehydration. So we want to be very keen. We want to start treating as early when we notice that they have no dehydration, so that they don't proceed into the dehydration again. So the aim is to give extra fluid. We want to give extra fluid to prevent them from developing dehydration. So ORS, again, the oral rehydration salt is used, And here we don't give throughout like in some dehydration. Here we give 10 meals per kg. So if a child is 10 kgs, we give 100 meals. So we give after every loose stool. Every loose stool. If you don't have loose stool, we don't give. We just keep feeding. But if we get a motion, a diarrhea motion, a diarrhea episode, we give 10 meals per kg of the ORS. I hope it's very, very clear. Then you should again encourage breastfeeding and feeding other food and also other fluids. You just don't concentrate. You can give some tea. You can give the normal water. Also keep giving those things. So we are saying you don't want these babies to develop dehydration because they just have diarrheas, but they don't have dehydration. No dehydration is what we are treating. So again, after giving, you reassess. Note that in each classification, when you are treating, after treating for the first time, we are reassessing just to see if we are improving. If we are improving, what we do, we reclassify. If, for example, the child was having hypovolemic shock, we have given the fluids in boluses, and when we reassess, the child has moved into severe dehydration. So we reclassify and say, this baby no longer doesn't have the hypovolemic shock, and now we have severe dehydration. We reclassify according to the improvement in each classification. So there we use that. That is it about the treatment of no dehydration. We have completed treating all classifications of dehydration. Just to mention, in all cases of treating diarrheas and dehydrations, we use zinc. Remember the zinc sulfate. Just to mention something about zinc. Zinc, what are indications? Why do we use zinc sulfate? Zinc reduces the length and also the severity of diarrheas. So when we give zinc with the ORS, zinc, the length, it does not take long when you give zinc for this diarrhea like it could have taken if we just gave ORS alone. So that's the need of zinc. It reduces the length and the severity of this diarrhea. Zinc again reduces the risk of treatment failure. It reduces the risk of treatment failure, especially in persistent diarrhea. We also prevent future diarrhea episodes by giving zinc. Yes, we also prevent the future diarrhea episodes. So we try to connect in different diarrhea. So we give in all cases of diarrhea. It should be given in all children with any form of diarrhea on top of all these things. So then how do we give this zinc? We give according to the age of the babies again. In all cases treatment of these babies, we are using the kgs and also the age. So for children who are below 6 months, just note this, below 6 months, we give 10 milligrams of zinc sulfate, and that is, if it is in form of tablet, that is half of the tablet. The half of the tablet is the one which is 10 mg, and we give 10 to 14 days. So just don't give 2 days, give for 10 to 14 days, 10 to 2 weeks. That is good enough. It will have helped. And if these babies are equal to 6 months or above 6 months, we give the 20 milligrams of zinc sulfate. And now that is a whole tablet. The full tablet is the one which is 20 mg. And this we are giving to babies who are 6 months old or above. We are giving the whole of it, again 10 to 14 days. So now you know. I believe you have learned. So in case of anything, any questions, please don't shy off. Below you can comment, you can ask anything. My email is at the end of the episode. Please ask anything. I'm sure this is a sensitive topic. It is what we get every day there at home. So please ask those questions. If you need clarifications, again, feel free. Let's interact so that we get to help for everybody. So thank you so much for listening to me. We are going to continue with our next episode on we are going to finish up with the treatment of diarrheas. And thank you for staying tuned. If you haven't subscribed, hit that subscribe button, the red one. Subscribe, share these videos widely, leave a comment below Turn on your notifications to know every time I'm posting a new video. If you have watched this one and you haven't watched the other previous episodes, start from the diarrhea, from all those from the definitions until here, so that you're not lost, so that we move together. Thank you so much. Till next time.